Good afternoon. My name is Won-Ha Kim, and as the director of the Institute for Health Policy and Leadership, I want to warmly, because it's a cold day, welcome you to our Spotlight and Health Policy event. So the topic we wanted to feature today is maternal mortality, and that's in light of the fact that we have this coming Sunday, what do we have? Mother's Day coming up, as well as the fact that out of our 5-member team here at the Institute, one of us, myself, recently became a mom, and the other is also expecting to become a mom. So we thought it would be an appropriate topic to highlight. So our speaker today is Ms. Priya Vadula. She's our own in-house speaker here at our institute. She serves as a policy analyst, and she comes from her undergraduate training in University of Michigan in biological sciences, and then she received her master's in public health from Columbia University, where she focused on health policy and management. So we're very happy and honored to have her as our team and also to be our speaker today. So without further ado, I'll hand the microphone over to Ms. Vadula.
So, as a neonatal intensive care unit nurse, Lauren Bloomstein provided care for others' babies, and this time she was finally going to have one of her own. In her last trimester, she and her husband, who was an orthopedic surgeon, had purchased their dream home. She left the nursery walls unpainted because she wanted the gender of her baby to be a surprise. So she bought blue paint and pink paint and was planning to paint it afterward. On Friday, September 30th, 2011, Lauren and her husband drove down to Monmouth Medical Center, which was the center where she worked, to go in for a scheduled induced labor with the OBGYN of her choice. And on Saturday, October 1st, Haley Bloomstein was born, weighing 5 pounds and 12 ounces.
You get a decent collection too, 3/4 of the bag, so. Think about your options.
Okay.
Just remember, you don't have to do anything.
Alright. Okay, Daddy.
I wrapped it. Alright, well,
What is
needles.
oh, it goes in the needle
Yeah.
box? Okay.
Just all cleaned up.
In the first 90 minutes after she had given birth, Lauren began to complain of a stabbing sensation under her sternum. The doctor told her husband that it was reflux and gave her antacids and prescribed her opioids for the pain. Her pain continued to persist, and her blood pressure had increased by the hour from 160/95 to 169/108. For the next 8 hours, as little Haley's vitals were being monitored, Lauren's blood pressure was not. And as the conditions worsened, her husband reached out to colleagues who told him that Lauren was displaying the HELP syndrome: hemolysis, elevated liver enzymes, and low platelet count. It's a life-threatening version of preeclampsia, which is a pregnancy condition that's characterized by high blood pressure and signs of damage to organ systems. He had asked the nurses to run the lab tests, and they did, and they said lab tests did not indicate preeclampsia. Lauren's excessive blood pressure caused bleeding in her brain, and 20 hours after Haley Bloomstein was born, Lauren died of hemorrhagic stroke. The death of a mother changes the entire structure of her community with ripple effects for future generations to come. The United States spends more on healthcare per capita than any other high-income nation and has the highest maternal mortality rate of any developed nation in the world. An American woman is 3 times more likely to die from childbirth than a woman in Canada. And what's more, while other nations are seeing a decline in their rates, the maternal mortality rate in the United States is increasing. And at this rate, as you can see, we are not going to reach our goal of reducing maternal mortality by 10% between 2010 and 2020, as we had set forth for ourselves in Healthy People 2020. And there is one other troubling piece of this story, and that is inequity. There are profound racial and socioeconomic inequities in a woman's risk of dying. And poverty is a major risk factor, and so is race. In America, an African American woman is 3 to 4 times more likely to die from childbirth-related issues than a Caucasian woman. And in some cities, that ratio is 12 times higher. In the United States, the maternal mortality rate for Black women is comparable to low-income nations, but the maternal mortality rate for Caucasian women is comparable to high-income nations. So, taking all of this into consideration, we ask ourselves, what is going on? Why is the United States so terribly unique in this issue? One of the issues is the way that we define maternal death. And as you can see, there are 3 different kinds of categories for how we do that. So maternal mortality, which is something that it's a definition that we're all familiar with, or we may have heard it, is the death of a woman while pregnant or within 42 days of the termination of pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental deaths. Pregnancy-related death is the death of a woman while pregnant or within 365 days of termination of pregnancy from pregnancy complications or things that are related to that pregnancy. And finally, there's pregnancy-associated death, which is the death of a woman while pregnant or within 365 days of the termination of pregnancy, regardless of the cause of death. So this could include something like an accident or incidental causes. So, for instance, the Centers for Disease Control and Prevention says that in 1990, the maternal mortality rate, so within the first 42 days, was 7.2 per 100,000 live births, and went up in 2015 to 18 per 100,000 live births. But studies, such as the one in the Obstetrics and Gynecology Journal, finds that if you actually look at all of the death certificates and count the deaths that occurred between 42 days and 365 days as well, that number could be as high as 28. So we have different definitions and different numbers for how we are looking at the problem, and that itself can be an issue. Now, some people have stated that perhaps we have gotten better at monitoring, and that's why our numbers are going up. But studies have also shown that after controlling for things like that, the number is still high, and again, looking at our high-income counterparts, it's too high. And timing is a huge issue to how we're going to start defining the problem. So the a report from the 9 maternal mortality review committees published in 2017 found that 37% of maternal deaths occur during the pregnancy, but 45% of maternal deaths actually occur within the first 42 days after childbirth. And 18% of the deaths occur between 43 days and 365 days after childbirth. So when we look at that and we see that the majority of deaths are occurring actually after the childbirth, we try to look at what are some of those drivers and what is causing this. And so we have identified 4 key drivers that are leading to the increase in maternal mortality in the United States. The first is underlying health conditions. The second is C-sections. The third are opioids and substance abuse. And the fourth is the lack of access to perinatal care. So we're going to start off by talking about the underlying health conditions. So we know that the demographics and clinical characteristics of the pregnant women are changing in the United States. First-time mothers are now much, much older than they used to be. And a growing number of pregnant women have underlying health conditions that could increase the risk and complications during and after pregnancy, such as chronic disease, hypertension, and blood pressure. What we're looking at here are 2 different graphs, is the causes of maternal mortality worldwide. And some of the causes are hemorrhage, hypertension, abortion, and sepsis. But in the United States, those causes have actually been decreasing over time, and that suggests that our medical intervention and our medical technologies are getting better. But what is increasing and making up a bulk of those deaths is now cardiovascular conditions and cardiomyopathy. Now, the other driver that we have identified are C-sections. So as we all know, C-sections are a surgical procedure, which means that there's always a risk, and it can increase the chance of infections, blood clots, blood loss, and morbidity. So they're usually necessary in certain circumstances, such as when the mother is of advanced age, when the baby is in distress, if the mother is having multiple children, etc. Some studies show, and experts say, that 10 to 15% is considered the healthy rate for C-sections, beyond which the risks actually outweigh the benefits. But in the United States, 1 in 3 women get a C-section, and that rate has been increasing over time. C-sections are, again, like we said, they're risky, they're more expensive, and the recovery period is much longer. What's even more troublesome is that your rate of getting a C-section does not depend on your need for the C-section, but rather which hospital you walk into that day for delivery. And that's what this graph is showing right here. It looks like in Florida, it goes as high as 70% of the births being done by C-section. There's also one example that really highlights the issue. There's a condition known as Placenta Accreta, which is a condition in which the placenta grows through the uterine wall where there may have been a scar from a previous C-section. And that in the 1960s used to affect 1 out of every 30,000 births, and now it affects 1 out of every 500 women. So that goes to show you how much that problem has grown. Now, another cause in the rise of maternal deaths that we have identified are opioids. So I think we've all heard of the opioid epidemic that's been taking place in the United States. Opioid use for pregnant women has increased by a factor of 5-fold. So it's gone from 1.19 per 1,000 births to 6.63 per 1,000 hospital births. And the most troublesome fact about this is that 22% of women on Medicaid are being prescribed opioids during their pregnancy. Now, state reports really highlight the deaths that occur from substance abuse. So in Colorado, nearly 15% of maternal deaths that were investigated between 2004 and 2012 were related to an accidental overdose. In Texas, more than half of the pregnancy-associated deaths from substance abuse directly involved opioids. And in Massachusetts, 90% of the substance abuse-related deaths occurred between 42 days and 365 days after pregnancy. The last driver that we've identified is the lack of access to perinatal care. The first thing is defining perinatal, because when we think about care for pregnant women, we often think about prenatal care. But postpartum care is just as important. So why is prenatal care important? Well, studies show that women receiving no prenatal care are 3 to 4 times more likely to have a pregnancy-related death than women who receive prenatal care. So during these prenatal appointments, pregnant women have a chance to receive checkups, discuss potential complications, and come up with a plan that ensures that the mothers are taking care of themselves through proper diet, etc. Similarly, postpartum care is just as important, given that 65% of the deaths occur after the delivery. One of the common things that we think about when we hear the word postpartum is postpartum depression. So the CDC says that 1 in 9 women are likely to have effects of postpartum depression after pregnancy. More than that, 6.5% of the maternal deaths that occur are due to suicide. And we see that most of these deaths that are occurring within the 365 days. So it's after that 43 days to 365 days. So postpartum care matters. But it's not just medical care that needs to be provided at these appointments. There's a lot that goes into it. What happens after the mother gives birth? What happens, where does she go? What if she has no home? Is the condition dilapidated? So Jessica Crawford is a 28-year-old woman. She's homeless and in DC. And she discusses the importance of having a sheltered environment so she can focus on that recovery period. And she says that I knew it wouldn't be easy when I decided to keep my baby, but I don't believe that anyone should have to give up their children or not have children because they're poor or because they're homeless. She says, having this baby is the best thing that ever happened to me, and I know I'm going to be a good mother if I have available resources. The problem is they can give me job training and education programs, but if I don't have stable housing, none of that is going to be helpful. So again, this is a great chance, especially during these kinds of appointments, to capture those people who might slip through the cracks and connect them with social services. So these underscore the reasons why care is important. But the other part of what we identified is not just the perinatal care part, it's the access part. How do we define access? A lot of different ways, but the ways that we've done it is coverage, timeliness, and services. So we're going to break these down. In the traditional Medicaid model, this is before the Affordable Care Act was passed, Medicaid, which is the federal government's health insurance program, was only available to children, people with disabilities, and low-income pregnant women. And how did they define low income? That was women making up to 61% of the federal poverty level or less. And in today's dollars, that equates to $7,618 per year just to qualify for Medicaid. And it only covered 60 days postpartum. So from the time that the mother was pregnant to 60 days postpartum. And because we know that 18% of those deaths are occurring between the 43 days and 365 days, we've already identified a coverage gap there. Now the Affordable Care Act, it increased the limit that women would need to make to 138% of the income. So we went from $7,618 to $17,236 for an individual income. And states cannot go below that any longer. And as you can see, some states can opt to go above that and provide even more. Currently, 37 states have adopted something known as the Medicaid Expansion. So the Medicaid Expansion was something that was provided by the Affordable Care Act. And the Affordable Care Act said, if you want to expand Medicaid, not just to pregnant women, not just to people, not just to children, you can do it for all low-income people. So 37 states have done that. And so what that means is that now women will receive care in those states year-round. So you don't have to be pregnant, and if you're pregnant, you're going to receive care throughout. But the states that have not expanded it are still only going to provide care up to 60 days postpartum. Now, all of this, all the progress we've made could potentially be reversed given all the threats to the Affordable Care Act. So what we're seeing here is the graph on the left, right, of the states that have expanded Medicaid. On the right, we see a graph of the states in terms of their maternal mortality rate. And there's a little bit of overlap, but it's the states that have expanded Medicaid but still have high maternal mortality rates, which are going to be the next topic of our discussion, which is accessibility. The Atlantic did a piece on African American mothers in Washington, D.C. And what they found is that in 2017, there were 2 maternity ward shutdowns in hospitals and neighborhoods with predominantly low-income people and women of color. So that's what we're looking at right here. And so what that did for women who were in that area, who were covered with the Medicaid expansion, mind you, it meant that they had to travel more than 1.5 hours to get to the closest maternity ward. Some of those women had to decide between keeping their job and getting care. For other women, because they were limited by the kind of care they could receive, had to wait until their second or even third trimester to even get their first prenatal appointment in. When we have structural barriers like this that disproportionately affect women and people of color, this is known as racial residential segregation. We know that women of color tend to have less access and poorer access to quality health care services and information. And not only that, but what we're looking at here is not just a maternity desert, it's also a food desert. And it just goes to, again, underscore that idea of the racial residential segregation and all of the factors that go into that. Finally, the other piece of that is this type of services. So that was the last part of access. Go back here. And so women of color are more likely to perceive racial discrimination and care that is not culturally competent. So when we define access, we define it as coverage, we define it as timeliness, and we define it as the services that are provided. All right, so now to go back, in summary, the causes that we found as the drivers for the increase in maternal mortality are underlying health conditions, as women, first-time mothers are of older age and have different types of conditions. We've described C-sections and how they've been increasing over time, how they're risky, and how they can increase the risk of morbidity and mortality. We've talked about opioids and substance abuse. And we've talked about the lack of access to perinatal care, where we defined access as the coverage, timeliness, and services, how this disproportionately affects women, low-income women and women of color, and that both prenatal care and postnatal care are important. But my job here isn't to leave you feeling sad. It's to leave you with hope. And the way I do this is with a success story. There is one state in the United States that is single-handedly able to reverse the trend of maternal mortality deaths. And 1 in 8 infants is born here. So can I get a guess as to what state that might be? You can just shout it out. That's right, it's California. In 2006, the California Department of Public Health noticed that their maternal death had surpassed the average maternal mortality rate of the United States to a point where they were scratching their heads and said, this is just not done. So what they did is they formed a maternal mortality review committee that included key stakeholders such as hospitals, clinics, professional societies, researchers, policymakers, into what became known as the California Maternal Quality Care Collaborative. These are the founders. And the committee concluded, after looking at hundreds of reports of maternal deaths, that if they focused on just 2 situations, they could reverse the trend. And those 2 situations were hypertension and preeclampsia. They decided they were going to standardize the procedures, just like what you would do if somebody goes into cardiac arrest. But this wasn't just a series of guidelines. This was going to require a change in culture and a change in the mindset. They wanted the care team to begin with the assumption that when a woman comes in to deliver, that woman is at risk at that minute, and go in with that mindset when you're providing care. So what they did is they created toolkits that prepare the care team for any emergency complication that could possibly arise. So what we're looking at on the right is the Preeclampsia Toolkit. And what we can see here is that they say that as soon as the blood pressure hits 160/110, it's time to start doing something about it. And the toolkit outlines all of the measures that you need to take. If we remember, Lauren's blood pressure had hit 160/109. And in his deposition, her physician said that it wouldn't have been a matter of concern until it had hit 180/110. The toolkits are important. An example of what the toolkits recommend is a hemorrhage cart. So it's very similar to a crash cart, but it includes things like an IV line, an oxygen mask, and sponges and pads to count the amount of blood loss. In fact, the idea was so unique that they put it into an episode of Grey's Anatomy, and it went viral, and the physicians were getting tweets and asking, what is this and how do we use it? The hospitals have been so successful, the collaborative has been so successful that the toolkits are now used in 88% of all of the hospitals in California, and that covers 95% of the births. And together they decreased the maternal mortality rate by 57% from 2006 to 2013. Hospitals that implemented the toolkit noticed a 21% reduction in maternal morbidity compared to hospitals that didn't, which were able to reduce maternal morbidity only by 1.2%. And as a side note, Loma Linda University Health is implementing that toolkit. So the providers also provide a service known as a C-section calculator. And so what they're doing is offering hospitals the chance to count and keep track of how many C-sections they're doing and give them alerts on whether they've surpassed the recommended rate and how to reduce that rate. So as the hospitals started using that C-section calculator, they were able to decrease their C-section rates by 4 percentage points throughout the state of California. And the work of the collaborative was so inspirational that the Federal Maternal and Child Bureau developed something known as the Alliance for Innovation in 2015. So this alliance now includes 25 national organizations, 18 states, and 800 hospitals, and it provides safety bundles that are very similar to the toolkits. There isn't much data yet that tells us how those states are doing, but from early results, Illinois has been able to reduce their the timeliness it takes to respond to the hypertension treatment by 37 percentage points. While we have made great strides in the state of California, we still have a lot of work to do, and that disparity still exists. But we've outlined the causes, we've outlined some of the drivers, we've outlined the statistics, and we've talked to you today about a success story. So now I'm going to provide you with ways that we can start making that success happen throughout the country. We need standardized data collection. So, as I mentioned to you, we have different definitions of maternal death. Different sources are collecting different data, and they're putting out different numbers. And we need to standardize that. But we don't need to just collect the maternal mortality rates. We need to be looking at morbidity. How close was that call? So according to some of the data sources, about 50,000 women suffer from pregnancy-related morbidity, and I can bet you that number is much, much higher. The other thing we need is data transparency. So in the United States, we have 3 national systems for collecting maternal mortality data. In 2007, the Centers for Disease Control and Prevention said they were going to stop publishing their maternal mortality data because the other states hadn't caught up with marking on their death certificates whether a woman was pregnant within 42 days or 365 days at the time of death. So we didn't even know or collect that data or start collecting that data until 2003. And in 2007, we stopped presenting the data saying that the states haven't caught up yet. We need that to change, and we need data transparency so we can start understanding what is actually going on. And we need a consistent review process. What makes the United States so different than every other country that's doing well is that we're lacking a national review process right now, a national review committee. California, when they developed their maternal mortality review committee, that's when they saw the change. And we need that to happen on a national level. So right now, about 37 states are in the process of creating their own review committees, but as you can imagine, that's going to get muddy because every state's going to have their own way of doing things. So we do need a national process for that. We need accountability. What happens to those hospitals that are consistently underperforming, that consistently have disparity ratios? We need to hold them accountable, and we need to provide them with help and the necessary toolkits to be able to reverse and make a change. we need a national promotion of best practices. I remember after reading about California, I was pulling my hair wondering, why is every hospital not using these toolkits right now at this moment? We need that national promotion of best practices, and it needs to come from the federal level, or the national level, I guess. We also talked about healthcare coverage and access. It would be nice if we could expand Medicaid. If not, at least the states that have not expanded Medicaid, make sure that you're not just going 60 days postpartum, bring it up to the 365. Studies show that that's how you're gonna help save lives. We also talked about access. So just because you have coverage doesn't mean you're gonna have access if you have to travel multiple hours to get your appointment. So one of the things that states have now been trying to implement are community health workers, doulas, and telehealth services, which are showing some promise nowadays. And then finally, we need parental leave policies at the national level. Once again, the United States is one of the only high-income nations that does not have a national parental leave policy. And what a parental leave policy? Notice I didn't say maternal leave policy. It has to be a parental leave policy. What it does is it shows that we're invested in our mothers and that we care for them, and that it needs to be done with both the parents to help decrease the wage inequality. If only the mother's taking off and the father's going to work, we're perpetuating that cycle of wage inequality in the United States. So these are some solutions that I've proposed. Is anybody listening to us? The answer is yes. So just last year, we were able to pass 2 different bills. So the first is by Representative Herrera Beutler of Washington, and she was able to get her bill, Preventing Maternal Deaths Act, passed on December 21st, 2018. So the bill requests the Department of Health and Human Services to create a program that would allow grant funding for the creation of a national review committee, or at least promotion of national review committees in every single state. It would require state departments to create a plan and show what they're going to do about the rates in their states. And it would also require dissemination. But as we learn in the policy world, just because you pass a policy doesn't mean it's going to have an effect. So just in late April this year, leaders on the House Energy and Commerce Committee have sent a request to the various departments and agencies that were supposed to be doing something to ask them what they've been doing. Another bill that was passed was HR 315. So for any of you who aren't familiar with the lingo, HR just means it's a bill that was passed in the House of Representatives. So these are both representatives. And so the bill was HR 315, which was known as the Improving Access to Maternity Care Act. On the right is Representative Michael Burgess. And the act requires the Health Resources and Services Administration to identify and publish reports on the areas that have a shortage of maternity care professionals. Now, we have a couple more bills that are in the pipeline for this legislative session. And so the first is Senate Bill 116, known as the Modernizing Obstetrics Medicine Standards Act of 2019, or the MOMS Act. And it would promote and update safety standards and best practices. So that was that national promotion of best practices we were talking about. That's what that bill would do. It would also improve the surveillance system of the Centers for Disease Control and Prevention, so that they're not just reporting on maternal deaths, but they're also investigating the maternal deaths. And then we have Senate Bill 916, which is known as the Mothers and Offspring Mortality and Morbidity Awareness Act, also known as the MAMAS Act. And this bill would expand the Medicaid coverage past the 60 days postpartum to 365 days for the states that have not done so. It would standardize data collection to create a uniform federal database. It would share best practices, and it would invest in ways to improve cultural competence and care. So I promise you, I didn't look at the bills before I created the solutions page. So it's nice to see that we're all on the same page. We're trying to get there, and we're making steady strides. And then just recently, when I was talking about that accountability factor, just recently, Senator Elizabeth Warren has proposed that we start rewarding hospitals that are doing a better job on decreasing that disparity ratio, and likewise talking about the hospitals that aren't, and trying to discuss why they aren't. So we're slowly making progress. But some of the most rapid change comes when the healthcare systems, hospitals, and providers get together and try and solve that problem on their own. Finally, I'd like to leave you with this because this presentation is dedicated to all of the pregnant women out there. The NPR did a recent year-long investigative report, and they knew that 700 to 900 women died every year from a pregnancy-related condition. In their investigative report, they were only able to find nearly 200 women. And that meant that 500 women and 500 stories were not being told, and 500 women were lost in the system. So this is to all those lost mothers out there. And I'd just like to leave you with one last thing. One maternal death is just one too many. I appreciate you for taking the time to come out here, and I welcome any questions. Thank you.